Antimicrobial Stewardship Rounds. My name's Casey Phillips, and I'm the lead pharmacist with the program. We also have Dr. Kathy Malashchik joining us today as our special guest, and we're going to be discussing something new we've started up in Regina called Micro Rounds. So what we're going to talk about today, it's going to be more of an informal presentation. Micro Rounds themselves are somewhat informal as of yet, but we'll discuss what are micro rounds and then get into how they help. And lastly, how do you join rounds if you're interested in this being something for you? And as we go with antimicrobial stewardship, we always start our presentations the same. For anyone not or anyone new to antimicrobial stewardship, it's a process of making sure that we're using our antibiotics, our antivirals, antifungals in the best way that we can so that we're not creating more resistance and we're getting the best outcomes for our patients. And the first question you have to come to is always, is an antibiotic necessary? And from there, if one is necessary, you go with the right drug, right dose, right duration, and right route. And there's going to be some similar processes that we can discuss regarding lab stewardship, and this is something that Kathy can get into, but similar processes are in place there where you want to optimize the sampling of the investigations that you're doing so that you're not utilizing resources and you're making the best use of the resources that are there and the tests that they have available. So an important point also is that antimicrobial stewardship is not about policing, shaming, or limiting prescriber autonomy. And the big point I wanted to make here is our program really focuses on collaboration. You know, when you look at Regina, there's three of us officially in the program, and we rely on those collaborations just to get the work done around the province that we need to. And this is something that we want to extend that collaboration into the microbiology group, just so that we're doing similar work. How can we better work together and learn from one another? And so this kind of brings us to the secrets of the micro lab. I don't know how many people have actually been in the lab, but for many people, I think it's still a place of mystery. Like, has anyone ever actually been in there? What goes behind those doors? Where is this lab place? And I remember one of the first times I was working as a hospital pharmacist here, and I'd been here for a number of months, and but I got a lab culture back on a patient showing resistance to a number of the agents, including the one that we were treating the patient with. And I asked one of the other pharmacists, well, what do we do in this case? And she just said, well, phone the lab and get them to tell you the unmasked sensitivities. And I thought, whoa, that's magic. Like, am I even allowed to do this? Is this something? And it was a process for me getting used to actually talking to somebody at the lab and knowing what information I could get from them. So micro rounds themselves, it's very similar to what's included as a regular component of infectious disease rounds. And you'll see these in larger centers. I was lucky enough when I was a PharmD student. I was in Toronto, and I was with their infectious disease service at Toronto General. And they had this giant established ID service where we'd have a microbiologist, the ID physician, a fellow, residents, clerks, and sometimes it'd be like 10 to 12 people. And we would, as a regular component of looking at our patients, we would go to the lab as well and look at the samples that our patients are growing, learn more about those bugs and the effective treatments for them. And for me, I found this just really enhanced my learning. And you know, I just remember the first time that they brought open the plate of Staph aureus and they were showing us, note the colonies and the color. Do you see how it's gold? And do you know why Staph aureus is called Staph aureus? Because AU, the chemical name for gold, that's why it's there. And that blew my mind. I was like, oh my God, I'm actually learning something that applies, or I learned something in Chem 101 that kind of applies to what I'm doing. Wow, this is amazing, bringing things full circle. So wanting to extend on that, I came and talked to Kathy and Jesse here at the Regina General, just discussing, how could we get something similar to this going in Regina? And everyone I talked to said, wow, that's similar like the process we had in Edmonton or wherever else. And everyone wanted to jump on board. And where I think this really helps is just in increasing that connectivity I was talking about. But also for us, there's a real clinical component to what we're doing here, but there's also an educational component. So what I want to talk about there is this is just increasing the connection between the ID team that we have, and so or anyone who's interested, and the microbiology department. So for right now, what we've tried to do with rounds is have our ID physician who's on call that week, myself as the pharmacist, any residents and clerks we have on, and others. And we give MRNs to the microbiologist for patients we want to look at. From there, we come in and we discuss the clinical background for what was happening with the patient, and we review all those cultures and the different sensitivities that we were looking at to try to figure out, okay, is there additional cultures we need? Are there additional tests that might help us narrow down and figure out what's going on here? And also, are we using the right antibiotic to treat this patient? And just really, it brings all those pieces together. And so far, we've had 3 sessions, looking at sort of like the Goldilocks principle here. The very first one, we had 4 people, which we found was too few. The next one, 14, we were a little kind of overflowing on the lab benches. But the last one was 8 people, which is just about right. And so, like I said before, we're really focusing on that medical core group of the medical micro, the ID physician, the pharmacist, and our learners, and then just bringing anyone else we can into there. And we've had a lot of good uptake from CTU, and we've even had Dr. Gibbings down there, and some of our ID physicians. So it's been a good turnout, and anecdotally, people are finding that this is a helpful and meaningful educational clinical component to what they do. And, just as an example, some of the topics we've discussed so far is just making sure to use the antibiogram to steer your empiric antibiotics, treatment of anaerobes, and where does different, clindamycin is falling out of favor with B. fragilis coverage, so what are better options? Also testing and treatment of Clostridium difficile infection. If we had a patient who was tested positive, they're now asymptomatic and they're tested again and they're positive but without symptoms, does that mean we treat again? And the answer was no. So it's good that we have these conversations just around appropriate testing, appropriate treatment. And, the list of topics continues to grow, and it's been really good so far. From there, I'm going to pass it over to Dr. Kathy to discuss a little bit more just about how these rounds can help you as a clinician or as a learner.
Thanks very much, Casey. It's quite an exciting venture, I think, for us in the lab, because I think ultimately it's patient care that benefits. And I'll try to give you a few examples of what I mean. So in our lab, there are hundreds of specimens processed daily. And unfortunately, this is the kind of typical clinical information that is provided. And so you would have patient demographics like age, gender, patient's name, obviously, and superficial wound swab and CNS, and that's all that you get for clinical information. So that is unfortunate because without clinical history, the interpretation of culture results is a huge problem. And just to illustrate, we're definitely not sterile. This is just a schematic of your skin microbiota, and you're not meant to maybe read that, but just to look at the different colors and appreciate that your obviously bacterial distribution across your entire body is significantly different, as illustrated by these different pie graphs with all the different colors of bacteria. And what is normal in one area for the body in terms of bacteria is completely different in another area. And so what is all normal also changes with age, occupation, diet, when you're talking about GI flora as well. So this is all, the interpretation of cultures has to be really made in a clinical context. And without this information, we're kind of just looking for the key pathogens, which we always work up. So, for example, for skin swabs or wound swabs, we know that Staphylococcus aureus and beta hemolytic streptococci, like your strep pyogenes, group A strep, group B strep, and C, and so on, would be the typical pathogens. But when you get an E. coli, well, is it a pathogen or is it not? Well, that totally depends. Is it, for example, a specimen from a infected diabetic foot, where E. coli perhaps would be a pathogen, or is it, a child with a scrape on their thigh who's in diapers and E. coli is hanging around because it's just part of that normal flora of the area? So again, what the team brings is absolutely essential clinical information that allows the lab to make appropriate decisions of workup regarding workup of the bacteria, and therefore provide the clinicians with more meaningful and clinically relevant data. And so we learn about anatomic location. So is this a leg swab? Is this an eye swab? Is this a head scalp swab? What is the clinical status of the patient? Are they diabetic? Is this a query necrotizing fasciitis? And therefore, we should be working up, kind of a mixed GI flora picture in a person with type 1 necrotizing fasciitis. Is it cellulitis and somebody swabbed maybe inappropriately, and all you get is Staph aureus, which is maybe normal for that area, where group A strep is the toxin-mediated disease that you're not going to find out on a swab, and therefore you're going to be treating staph where you should be actually treating group A. Where was the specimen collected? So this was an actual case where we received a knee swab, which we thought was, just collected at the bedside of a wound on the knee, but it actually happened upon further discovery with the team that this was a surgically obtained intra-articular swab, so basically a joint space, which we would treat quite differently. And the skin flora that was reported on a wound swab was actually significant and worked up more and reported all the all the bacteria were reported with appropriate antimicrobials, and they were all significant. Also, very important partner history is also something that we can glean from the interaction with the team, such as, do they have a travel history? What's their occupation? Are they, for example, a vet, and, that Streptococcus canis in their wound is actually significant versus just a colonizer or contaminant? And ultimately, having the team there at the time to give us a heads up about a specimen workup allows us to provide the results in a more timely manner, as opposed to somebody calling you back and saying, oh, no, we have to dig up that specimen. It's been now 3 days, so we have to subculture it. That's going to take another 24 hours. And by 48 hours from then, you might, get what you were looking for. So again, invaluable information for patient care. There are more benefits of multidisciplinary rounds that extend past the patient care aspect, and that's, I think, very important, is ongoing professional development. So just as a show of hands, or you can chime in if you're on through WebEx, how many of you have done a elective in infectious diseases? Now, I see some hands going up. The ID people are not allowed to do that, but right, so for those who may not have, I think that's a very valuable experience to have. How many of you have maybe been in the microbiology lab or have done elective in other areas of lab medicine? And again, I think that the number of responders may be even lower than the first one, because it's not something that people are maybe even aware of, that microbiology is a specialty within lab medicine. And how many of you may have asked the question, well, why are there no susceptibility results available on this E. coli that I just got, phoned about positive on culture today from this blood culture? Well, that's because you're probably not understanding the workflow of the lab and how specimens are cultured, how long it takes for things to grow, etc. So I think it's very beneficial to have people rotating through because otherwise the lab is kind of a black mystery box where specimens go in, something happens, partly magic, partly witchcraft, and then results are generated. So again, by joining us on these rounds, you will invariably become familiar with the way that the lab works and specimens are processed. You will learn about fascinating new technologies that are allowing us to decrease the turnaround time for results. And an example of this, and you see this on the lower right-hand corner, is the MALDI-TOF MS, or the matrix-assisted laser desorption and ionization time-of-flight mass spectrometer, which is allowing us to do basically identification of bacteria in a span of 10-15 minutes as opposed to 18 hours. And with the use of this technology, we're able to provide you with identification of bacteria also in many of the specimens from blood cultures directly. So very exciting technology. You will also learn about the new test that we introduced, and that is the Gene Expert MSSA MRSA PCR. That is a kind of a black box, fully automated technology that you are able to take a blood culture obtained from a patient that rings positive on our instrument, on our incubator, sample that, put that into this black little box, and then off it comes as MSSA or MRSA. So it allows you to actually obtain clinical or relevant treatment information, susceptibility for these very common bacterial pathogens in blood cultures. So again, very exciting, and there are many others that are in the process and are currently incorporated into the routine workflow in the lab. And it also provides the learners with a way of understanding what maybe ID docs, the way that ID docs think, and we look at cultures with both gram interpretation, culture interpretation, etc., but also tying those microbiology results into with relevant clinical information and clinical history of the patient. So we've talked about, if something is seen on gram but it fails to grow in culture, what does that mean? If something is positive by PCR but is negative by culture, what does that mean? Why are the different modalities important? And I think it's important to realize, and that's the environment that we'd like to create for the micro rounds, is that there are really no stupid questions, so that all questions are welcomed. And obviously there are different levels of learners, and everybody should feel comfortable by asking whatever they want to ask, actually. And so the kind of last benefit that I think is, again, a little bit self-serving for a lab professional is laboratory stewardship. So we hope that by discussing with the learners about what specimens to submit, why do we submit certain specimens, why not to submit certain other specimens, how to enhance their quality, etc., that we will limit the workup of poor quality specimens. So for example, swabbing of cellulitis, versus actually maybe taking a tissue biopsy or something, or instead of swabbing pus, actually getting a collection of the discharge itself. Also limiting the submission of specimens for which treatment is not recommended. So we all know the big problem that we have with asymptomatic bacteriuria, and many people still think that having a foul-smelling urine or a cloudy urine in itself without any symptoms of urinary tract infection is sufficient enough to query a UTI. So hopefully through these rounds and through the ongoing discussions, we can dispel some of those myths. And it's not about decreasing, lab utilization. It's about appropriate laboratory utilization, which in many of the instances actually means sending more specimens, as long as they're appropriately collected and high quality, to tailor the antibiotics appropriately when those cultures come back. So another essential thing for antimicrobial stewardship, of course. And, the very practical side of having micro rounds is that, we're now able to put a face to that name or voice that you've heard or about or talked with. You know, there are people in the lab. It's not like a TD Bank you call and get an automated answering machine and press 1, 2, or 3 and so on. So you can actually have a discussion about a patient that you have concerns about, and instead of just getting a, no, you can't have the susceptibility, or no, we're not releasing that. So there's more to us than that. We are a resource. There are 2 of us, myself and Dr. Jessica Minion. And specifically for the learners, I think it's important to realize that they can call and have a discussion and don't feel necessarily like they will be quizzed, which seems to be a surprising thing for many of the residents and the learners. And I'll give it back to Casey.
Yeah, so finally, we're just going to quickly go over how to join rounds. And this is, we're building this process. And the reason we wanted to discuss it today is just one more way of enhancing stewardship. And for us, it's about creating those connections and building on the clinical and educational components. As we continue to build it, there's going to be some changes, but I hope you can work with us through that. The easiest way to join rounds is to email myself. We've got the email up there. What we would need from you, however, if you want to come join rounds, is the patient information for which patient you want to see. So in that case, some identifiers like their name or their MRN, the specific cultures to be reviewed, because different patients can have a number of cultures to look at, so specifically what you want to see. And then also when you come to rounds, bring that clinical background, knowing the patient's story, just so you can present that to the micro staff and we can work back and forth to put that story together. Right now we're doing them on Wednesdays at 2:30 in the afternoon, but that time can change. It just depends on how it works for everyone who's interested in coming. And for our meeting place, we're just meeting outside the lab doors. So hopefully we'll get more people out, and make sure you email so we can just keep it to a reasonable number. And a couple last points, just there's always a plug in here for us just saying we have our regular resources on our website as well. So for anyone needing to look further into stewardship resources, we've got a great website. There's also the antibiogram and the app that we can upload current antibiogram data to as well. And also, just for your resources, call the microbiologist via switchboard if you do have those micro questions. And lastly, just wrapping it up again, changing the way we view antibiotics. One point we've really been trying to make is just looking at antibiotics in a bit of a different way as a societal medication. We don't have, we have a limited number of uses with these medications before they develop resistance. So we really have to look at them socially and make sure that we're using them correctly so that the people who need them most will have them available when they need them. And from there, I think that's it. We can open it up for questions, perhaps at the WebEx and distance sites. Yeah, just unmute your phone if you have a question.
Crystal clear.
No questions. And no stupid questions, remember? We already said that. And I'm usually the one asking the stupid questions at the round, so I need other people to join me and share that burden. Please. Any questions? Do we have?
Indian Head still.
Okay, question from Indian Head?
No.
No? Okay. All right, no questions from here.
This is Kelly Lloyd from Larange. Can you hear me?
Yeah, we can hear you. Go ahead.
Okay, so I'm a wound clinician, and I'm under the impression that the Levine technique is the best for collecting off of the surface of a wound. Again, there's the question why.
Sorry, can you repeat that again? Which technique?
Levine.
Oh. I'm not a wound clinician, and so I'm not very well versed in that area. So could you care to elaborate on that?
Well, we clean the wound first with the irrigation and take a swab and push in a pink area of the wound surface down with a significant amount of pressure to express actual interstitial fluid, and that's the specimen that we are attempting, I believe, to send to the lab. But I would like any comment from you as to, is that the direction we should be headed in our collections, or is there something different you would like us to do?
No, so with regards to specimen collection, I think the important thing is to be able to kind of understand the signs and symptoms of a skin soft tissue infection in chronic wounds, because, you know, they can be tricky. But with regards to the protocol that you described for specimen collection, I completely agree with first cleansing the area, because obviously we are colonized with bacteria, and any open wounds are just additional food for the bacteria. And so they need to be debrided first, because you don't want to get the bacteria that colonize the wound. You actually want to get the bacteria that are lying kind of at the deeper layers that may be actually causing the infection. And so I think that's where the rinsing or the debridement, the washing comes in, and then obtaining a kind of a deeper specimen where the pink areas, kind of the more healthy or bleeding tissues are. Does that kind of answer the question? I don't know if I answer that very well.
No, I think that's good, as long as we're on the right track. And of course, we recognize that most of the wounds are colonized. So then again, the question of why are we doing that? So I think people are hasty to run ahead and say, oh, well, we really should swab that. And I'm saying here, no, we really need to.
Exactly. Yeah. So it goes back to that initial, is this infected question, which is, I agree, maybe a difficult one to answer, because they can be weepy. They don't necessarily have to be, you know, outright purulent, but that's exactly what we're looking for. Redness, warmth, purulence, a change from their normal baseline status.
Right, and recognize the host factors where the person may or may not be able to mount an immune response and show signs of a deeper tissue infection.
Absolutely, yeah. All those things are excellent to consider, absolutely.
Okay, good to affirm we're on the right page.
Yeah.
Thank you.
Thank you.
And Dr. Betcher, we had a question?
Question I had, because those rounds are at 2:30 on Wednesdays, which is right when we're doing rounds in medical ICU. So it would be hard for us to go. But if we had something outside, often if we have like imaging, we'll go down and we'll talk to the radiologist. So what if we had something that we wanted to discuss? Can we just come down to the lab and discuss it?
Absolutely, yeah. Okay. I would say call in advance just to make sure that we're there. We're often in meetings, but yeah, absolutely. Call anytime.
All right. Well, thank you, everyone, for coming out today or tuning in, and hope to see you next month.
Thank you
so much.